Hello, welcome to tonight's Ophthalmic Clinical Education Summit. This is our program tonight on imaging. Thank you for joining us today. This is a live program. Here's my panelists for tonight. First, I'm Rishi Singh from Cleveland Clinic in Cleveland, Ohio. I'm joined by Dr. Miguel Matern from Duke University, and also Dr. Sarah Reed from Retina Consultants of Hawaii. The agenda for tonight's discussion is we're going to discuss some of the imaging basics in retina. Sarah is going to take us through a nice discussion on that. Then we'll have some panel discussion as well as some case presentations both from Dr. Reed and Dr. Matern. And then we'll turn it over to looking at more of the futuristic ways we're going to evaluate these images and how artificial intelligence plays into that with one of the chief scientists at Zeiss, Carl Zeiss Meditech, Dr. Manavan, who's going to come and enlighten us on the newest technologies that Zeiss is employing in some of their imaging modalities. And then finally, we'll have a wrap up and a Q&A. And here's a disclaimer slide for tonight's program. And I'm going to turn it over to Dr. Reed to start off the program discussing the imaging basics of retina. So with that, I'll turn it over to Dr. Reed to start the program.
So thank you again for having me. The first part here will be talking about imaging basics in retina. And so my name is Sarah Reed, and these images are taken from patients cared for at Retina Consultants of Hawaii by either me or one of my three partners, Greg Kwakame, Jim Lai, and Ray Wee. So we're going to be talking today about multimodal imaging, including color fundus photos, fundus autofluorescence, fluorescein angiography, and ICG angiography. I find fundus photography to be especially helpful in a number of instances when taking care of patients, and it's helpful to kind of have an organized way of looking at the photos, focusing on the vitreous, the disc, the vessels, macula, and the periphery. Often I'll use it as a baseline imaging for future comparison. This is an example of a choroidal osteoma. This patient eventually developed choroidal neovascular membranes, and so it was helpful to follow the growth of the osteoma as well as complications from the CNVM. It can also be useful to document fine details, especially in the periphery. This is a diffuse choroidal melanoma. Here you can see the feathery borders of the lesion as well as the subretinal fluid. One of the nice things about the Zeiss True Color is that you can pick up subtle pigmentary changes. This is an example of oculodermal melanocytosis, and you can see here the increased pigmentation in the left eye compared to the right. And this is also seen in the iris heterochromia as well as the scleral discoloration. Specifically, when looking over time, it can be especially helpful not only clinically, but also to educate the patient as to how treatment is going. This is a patient with intraocular lymphoma that was treated with local therapy with intravitreal methotrexate. You can see resolution of the subretinal lesions. Often in clinic, I'll be discussing surgical options with patients, and fundus photography, especially peripherally, can be helpful in talking about rhegmatogenous detachments and optional tractional detachments, as well as using laser barricade for subclinical detachments. So in this last photo here on the right, you can see that laser barricade was used here, and this can also be helpful to follow the patient over time to ensure that there's no progression of the detachment past the laser. This is a pediatric retinal detachment treated with a primary scleral buckle, and so here I can show the patient that the fluid has resolved and that she's doing well. Preoperative documentation can also be helpful for medical legal reasons. This is a chronic RD that was referred to me, and then on exam, I found that the patient had an intraocular foreign body. I often will use fundus autofluorescence as an adjunct to conventional fundus photography. Autofluorescence relies on the intrinsic fluorescence emitted by ocular tissue after stimulation by an excitation energy. And there's a natural autofluorescence to a number of tissues in the eye, including the corneal epithelium and endothelium, the lens, optic nerve head drusen, as well as macula and RPE pigment. In the retina, the lipofuscin within the photoreceptors causes autofluorescence, and this is due to the A2E component. The lipofuscin accumulates within the RPE during outer segment phagocytosis as part of the visual cycle. And so autofluorescence can be used as a surrogate for health of the RPE. And so we'll see hypoautofluorescence with severe RPE atrophy. And so this is a case of Sorsby's fundus dystrophy confirmed by genetic testing positive for TIMP3. And here we can see the autofluorescence really shows us the areas of RPE loss. And this can be helpful to follow progression over time. In some diseases, increased autofluorescence can be a marker for disease activity. This is an example of persistent placoid maculopathy, which is on the spectrum of serpiginous and AMPI. And autofluorescence can be used to properly mark the borders of the lesion, but also increased autofluorescence at the lesion borders can indicate increased activity of the disease and can help to guide immunosuppression. This is a patient referred for atypical optic nerve appearance, and here on autofluorescence, you can see the clear optic nerve had drusen. Peripheral pathology, especially drusen, can often be visualized well with fundus autofluorescence. This is an example of a young patient who had glomerulonephritis, and so this is glomerulopathy-associated drusen, which is a relatively rare disease, but you can see here the striking visualization of the drusen on autofluorescence. More commonly in my clinic, vitelliform lesions can occur both in this case, which is a adult onset foveal pigment epithelial dystrophy, which is a form of inherited pattern dystrophy, but also as a complication of reticular and cuticular drusen. And then in this case, subretinal deposits accumulate due to RPE dysfunction. It's important to differentiate this from choroidal neovascular membranes. So usually these patients have a relatively good visual prognosis, and most importantly, these lesions don't respond to anti-VEGF therapy. Fluorescein angiography is a mainstay of retinal diagnosis. It helps to visualize the vascular anatomy, but importantly, it shows dynamic visualization of the retinal vasculature, both with hypofluorescence, usually seen with blocking and non-perfusion, as well as hyperfluorescence, such as window defects, staining, pooling, and leakage. And we'll go over all of these patterns. Hypofluorescence, as I mentioned before, can be caused by non-perfusion. As you can see here, this is an area of capillary dropout. So in this case, the fluorescein is not visualized in this lesion simply because the blood vessels are no longer present in this area of the retina. In contrast, blocking is caused by an overlying occlusion, in this case, a hemorrhage, that's blocking the visualization. And we'll see this in a number of disorders, but commonly with hemorrhage, we'll see this in clinic. Hyperfluorescence is caused by four common patterns: a window defect, and this is where a defect within the RPE allows visualization of the choroidal circulation. The choroidal circulation occurs early in the course of the FA and the choroidal flush, and so you're able to see an early hypofluorescence in the area of the RPE defect as you're able to see through that window into the choroid. Staining occurs usually with a scar and is a slow accumulation of the dye. Pooling is an accumulation of the dye within a contained space, such as PED or subretinal fluid. And leakage is leakage of fluid out in a less organized way due to leaky blood vessels that we see in macular edema or neovascularization. And so when we're looking at how these patterns occur in the FA, it's really important to follow the pattern over time. So a window defect, as I mentioned before, you're able to see the choroidal circulation. So usually there's an early hyperfluorescence that tends to fade over time as the choroidal fluorescein is washed out. In contrast, staining will stay relatively stable in size, but will increase in brightness as more and more of the stain is soaked up, kind of like a sponge. In pooling, you'll find that there can be an enlargement of the area, but into a discrete container or cavity within the anatomy. In contrast, leakage will get brighter and brighter and less distinct in its borders with time. With window defects, we'll see this in areas of RPE loss, such as tears, degeneration, and defects. Staining occurs whenever the dye is soaked up by lesions, such as a scar, fibrovascular tissue, drusen, or even the optic nerve. Pooling occurs in serous retinal detachments or pigment epithelial detachments. In leakage, as I mentioned, leaky blood vessels, such as macular edema or neovascularization. So let's go through a few examples of these. So we'll start with the window defect. And so this is a case of peripheral panretinal photocoagulation. And in the areas with the laser scars, you can see that there's loss of the RPE, and this allows you to directly visualize the choroidal vascularity. In the center macular region, where there's intact retinal pigment epithelium, the RPE blocks the choroidal fluorescence. However, in the periphery, with RPE loss, visualization of the choroidal vessels now becomes visible. This is early in the FA during the choroidal flush. In staining, we get a slow accumulation of the dye. And so this is peripheral panretinal photocoagulation scars. You see early, you can faintly make out the scars. And as we get later into the FA, those scars become more and more distinct. Going back to the FA that I showed previously, where early in the FA, we were able to see the choroidal fluorescence. As we move through the angiogram, we see that those PRP scars now start to take up the dye and start to block the choroidal fluorescence that we saw earlier. And so early we see a window defect, and late we see staining. And so this is a nice example of two kinds of hyperfluorescence in the same area occurring at different points during the angiogram. Pooling occurs as dye accumulates within a cavity. And so the most common one we'll see is in retinal detachments due to central serous. And the classic finding is of a smokestack area of leakage that pools into the serous detachment. But it occurs in other forms of serous detachment as well. And so this is a slightly less common disorder called Harada's disease. And this has to do with inflammation of the choroid leading to multifocal serous retinal detachments. And so we can see that there's focal serous retinal detachments as well as those occurring in the macula. Early in the angiogram, we can see pinpoint hyperfluorescence. But as the angiogram progresses, we can see that there's late pooling within these areas of serous detachment. In contrast, leakage will have less and less distinct borders with time. And so this is an example of optic nerve head edema. Early, we can see vascular congestion, and with time, the borders of the nerve become even less distinct as the dye leaks out of the vessels. Neovascularization of the disc, you can see over time, from the early to the late angiogram, that a hypofluorescence increases and leaks out into the vitreous. Importantly, with Widefield angiography, we can actually visualize areas not in the macula quite easily. And so in this case, as we go through time, you'll see infranasally an area of leakage corresponding to NVE. And so if we go back through here, early it's not visible. With time, you can start to see that collection of blood vessels, and they become increasingly indistinct as the dye leaks out and obscures the borders. So just to review, window defect allows you to see the choroidal circulation. Staining is a stable sized lesion that increases with time as it accumulates more and more dye. Pooling is accumulation of dye within a contained cavity, and leakage of dye is out into space and becomes less distinct with time. Our last imaging modality is ICG angiography. ICG fluoresces on the infrared spectrum and so is able to penetrate the retinal layers, making circulation of the choroid visible. So if you remember with fluorescein angiography, with the intact RPE, we weren't able to see the choroidal vessels unless there was a window defect. ICG allows us to cheat around that and see the choroidal circulation even in intact RPE. Because ICG is almost completely protein bound, there's limited diffusion through the small fenestrations of the choriocapillaris, which allows more fine-tuned imaging of the choriocapillaris and especially of choroidal neovascular membranes. So if we look here on the left, this is fluorescein angiography, and then on the right, you can see ICG. And so you can tell the difference immediately that though both show the retinal vessels, only with ICG are you able to clearly see the choroidal vessels with intact RPE. And this can be helpful in looking at choroidal neovascular membranes. And this is an example of AMD, and this is an ICG hotspot, or polypodochoroidal vasculopathy. And here we're looking at a polyp. And this is a less common disorder. This is called birdshot chorioretinopathy, which is one of the white dot syndromes that causes multifocal inflammatory lesions within the choroid. Fluorescein angiography is relatively nonspecific as far as the changes, but ICG really shows these areas of hypocyanate spots in the late phase corresponding to the areas of inflammation, especially seen clustered nasally, and so this really clinches the diagnosis. So sort of to tie it all together, I use multimodal imaging often in clinic, both to make a diagnosis, to help understand the prognosis of disease, and to follow the disease over time. Thank you so much for sitting and paying attention, and I will be talking with you in a few moments. Thank you again.
All right, great talk. And so our panelists will now join us for a live Q&A. And thank you, Sarah, for that discussion. So let's talk about, sort of the more relevant recent events with regards to COVID-19 and how you're managing it. You presented such beautiful photographs, but sometimes people might feel like these are time consuming and there's concerns around COVID and exposure. How did you, and maybe I'll hear from Miguel as well, how did you both manage this in your practice recently?
Thank you so much. I just want to make a quick mention. Unfortunately on Zoom, I think the images got a little degraded in the delivery. So one of the things that I love about the Claris is that with a single image, you can actually zoom in and get really good visualization of the macula, of the optic nerve, as well as things going on the periphery. I would say one of the most helpful things with COVID is that the Zeiss camera works quickly. It's easy to position the patient. I find that usually the time that I'm closest to the patient is when I'm examining at the slit lamp with the 90. And so being able to have a photograph that's reliable that I can use to look at a lot of different areas of the retina can limit some of the face-to-face time with the patient actually in the chair. And I think can actually speed along the visit a little bit. The fact that it also is such a quick interface for the photographer also makes it, sort of safe to get those images in clinic. So I think it's really helpful in a lot of ways to incorporate imaging into your clinic to try to move it more quickly and to limit the close proximity that you have with patients, especially when you're still seeing a number of patients a day.
Yeah. Miguel, do you want to comment on kind of your changes in practice due to COVID and with the use of imaging in particular?
Well, two things. One is how COVID could have affected our clinic. In the field of ocular oncology, we could not stop seeing our patients. And regarding the imaging, we have not changed our practice. So photography, images, good quality images is key in our practice. So yes, we took all the precautions about COVID, but in terms of how to change our clinic, no, just adding precautions, adding more time maybe, but as I said, this is key in our practice.
Yeah, I would say it's the same for me in Cleveland. We see retina patients. Retina patients are getting imaging for obviously particular needs. Sarah, you demonstrated so many great cases there that have obviously clinical implications on how you manage these patients. And so I think it's a very, very different need compared to maybe a cataract surgeon or a glaucoma person who can potentially forego something. So I agree. We did the best we could to space the patients appropriately in our practices. So we had, a waiting room that was only now a few chairs versus being very many, and we moved a lot of that waiting area to the outside spaces as much as possible. And we also tried to order imaging on unilaterality specific imaging. I think that was another thing to kind of speed the process along. If there was anything going on in the fellow eye, we wouldn't image the fellow eye for any reason, but you can see how some of those cases are very helpful. Both for Sarah and Miguel, and maybe in your particular practices, I'm enamored by always the discussion around fundus autofluorescence. I think it's a fantastic technique, and you showed a few good cases there. Tell me, in your routine AMD patients, are you getting this? Or Miguel, tell me in your practice with oncology, is fundus autofluorescence really valuable to you? Let me hear from both of you.
So I'll jump in first, sorry. So I would say that I use autofluorescence a lot. It's one of my favorite tests. I think it's useful in a lot of different ways, especially for AMD. I think it's a good way to be able to follow conversion to geographic atrophy and be able to follow those lesions over time. So I often will get baseline autofluorescence, peripheral degenerations. I think it's helpful. So I use autofluorescence a lot. And especially I've found that you'll always find some, especially if you're looking at patients that maybe don't have pathology or more subtle pathology, you'll end up finding some clues to the diagnosis that can help you. I mean, I think a lot of us use it in central serous, but the teleform detachments, all sorts of things, I think autofluorescence can really help you clinch the diagnosis and is very helpful.
Mm.
And in our practice, definitely autofluorescence many years ago have helped to improve our diagnosis weapons. And one key point here is that we try not to have one particular test to say, well, this is this because of the autofluorescence or the OCT. We try to put everything together to come to the diagnosis, and definitely autofluorescence, we do use that routinely. Yes.
Yeah. Yeah, I think, Sarah's case has illustrated what we all do in clinical practice, where it's really multimodal imaging together and taking all of those images together to understand best what to do with that patient. I particularly have found differences in the cameras regarding fundus autofluorescence. I don't know if you've perceived that at all. The one big difference I found is that in the Claris and in the FF450, which is the old Zeiss camera, and even the Heidelberg, the images are much better than the Optos. I don't know if you guys have experienced that, but I find a lot of washout from the fundus autofluorescence. Do you have any thoughts on quality of fundus autofluorescence cameras, or what you have found, generally speaking, with regards to that?
Well, yes, I have. I've been looking for a wide angle imaging, non-contact, with more real color, and if it can provide, wide angle OCT, we have a wide angle autofluorescence, wide angle fluorescein angiography. I mean, for us, it's key. Everything sounds key for us, but it is. And when we need to make decisions, and when we need to face the patient and talk about, well, there is most likely a cancer, this is most likely benign, it's a huge difference for the patient.
Yeah.
I would say we use the Heidelberg. Oh, sorry. So we use both the Heidelberg and the Zeiss. I would say that great thing about the Zeiss is it's a good everything autofluorescence. Same for the fundus photography, but I feel like for Widefield, the Optos and the Zeiss are fairly comparable, but it's when you're trying to image both the macula and the periphery, or have a single camera to do both, that's where I think you really see the difference. Because I really feel like the great thing about the Zeiss camera is I can take a single photo and I can look at a lesion in the periphery, I can look at CSR guttering that's traveling below the arcades, but I can also look at optic nerve drusen at the same time, or really fine changes on the autofluorescence. And that's where I think the Claris really sort of stands apart, is that it's able to do multiple things at once, and you can get all of that in a single camera in a single photo.
That's great. You touched on ICG angiography, and I think it's sort of, it's never really had a large place in our practices, but I think both of you have found a lot of use in your own practices. And whenever I order one, the fellows and residents huddle around me like as if I just found the lost ark or something. It's so tell me where I should be ordering more ICG in my practice. Where have you found it to be very useful in your cases?
So, here in Hawaii, we have a larger polypoidal choroidovasculopathy population. And so, especially working with Greg Kokame, we do a lot of PDT. And so ICG is really helpful to characterize the lesion, to follow it over the time, and to sort of set your spot size for PDT treatment. It's also helpful in sort of giving some prognostic information to patients to be a little bit more anti-VEGF resistant. So I would say that's where I use ICG most routinely, is in looking at AMD versus PCV patients. We use it for other stuff as well, but that's where I think it really shines.
For us, is I would say the number one differential diagnosis is a circumscribed choroidal hemangioma. These can be difficult in the retina practice sometimes to recognize, and yes, I would say that's the main reason that when we order the ICG. In other circumstances, you know, is to prove that this is not a tumor. And, you know, in the oncology clinic, it's kind of usual that patients are referred because they don't have the typical retinal lesion. And they say, well, this might be a tumor, let's send it to oncology. And then our role is to say, well, I don't know what it is, but it's not a tumor, so go back to retina. And we use all these tools to recognize this situation.
Right. That's great. Okay, good. So maybe you've convinced me. Maybe I'll have to order my ICG and my treatment resistant. So, all right. So let's go on to our next section. We're gonna have a case discussion now. So I'll turn it over to both of you for that case discussion.
Great.
Thanks so much for that discussion. We're going to move on to the next area, which is case-based grand rounds. I'll be talking about vascular imaging, focusing on cases that have to do with retinal imaging as well as choroidal disease. So our first case is a 35-year-old female with no difficulty with light adaptation, diagnosed with diabetes 10 years prior. Her last hemoglobin A1C was 5.4%, and she was non-insulin dependent. On exam here, we can see microaneurysms, vessel attenuation, some obscuration of the disc, as well as peripheral hemorrhages. When looking at diabetic retinopathy, there are a number of hallmarks of disease. Angiography can be especially useful in these cases to really highlight some of the classic findings. Here we can see microaneurysms. These are usually the first visible sign of disease in diabetic retinopathy, and they're localized capillary dilations that you can see here, almost in a starry sky appearance. A more subtle finding, localized here infranasally, is a collection of blood vessels, and this is called an intraretinal microvascular abnormality, or IRMA. And these are shunt vessels appearing as abnormal branching or dilation of the existing capillaries, and this represents new growth versus possible remodeling of the existing capillary bed. Unlike neovascularization, this new growth is contained within the intraretinal layers and typically doesn't leak on angiography, which is what we see here. Both microaneurysms and IRMA are part of the 421 rule to diagnose severe NPDR that was characterized by the EDTRS study. The last is venous beating, and so here we can see microaneurysms, as we saw in the last slide, and then the venous beating here is these dilation of the venous vasculature. And this is one of the nice things about Widefield angiography, is you're able to capture in a single imaging scan different pathology both in the macula and the periphery with good detail. Looking closely in the macula in our patient, we can see that this area of the nerve that originally showed some obscuration, and then we can also look closely at this infranasal area. You can see in the late phases of the angiogram that we see leakage at the disc, consistent with diabetic papilledema, as well as leakage here showing an area of neovascularization. And so this patient had proliferative diabetic retinopathy with diabetic papilledema. Non-proliferative diabetic retinopathy can be visualized as part of an angiogram, but I will often also use OCT angiography to characterize areas of capillary dropout. And this can help to explain decreased vision that can be limited by enlargement of the foveolovascular zone or large areas of capillary dropout, and can help guide prognosis and treatment for patients. In high-risk proliferative diabetic retinopathy, we can look here and see that there is significant neovascularization of the disc in both eyes. OCT angiography can also be used in this case to look more closely at the neovascularization and actually visualize these neovascular fronds coming up into the vitreous on the VR slab. High-risk proliferative diabetic retinopathy, here treated with panretinal photocoagulation, OCT angiography can help us to visualize areas of vascular non-perfusion and can guide additional PRP laser if needed. For our second case, this is an 83-year-old female who presented with painless vision loss in her right eye. Of note, she was monocular in the right eye due to wet macular degeneration in the left eye. Her right eye symptoms started 6 hours prior, and her vision had decreased from 20/25 to 20/50. She had a history of hypertension and hyperlipidemia. And this is the OCT of the right eye. Now I'd like to draw your attention to the hyperreflectivity of the inner retina that we see here. Looking at the imaging, the left eye, you can see that there is the subretinal fibrosis, consistent with her end-stage wet macular degeneration. In the right eye, the findings are slightly more subtle, though you can appreciate some mild optic nerve pallor here. It's really in the peripheral scans that we can see the vascular changes that are the hallmark of this disease. And especially on angiography, we can see boxcar segmentation with slow segmental blood flow through the arteries that characterize an arterial occlusion. The veins remain of relatively normal caliber. Importantly for this patient, if we look at the angiogram of the macula, we're able to see good blood flow through the superior artery. And this is because this is a cilioretinal artery, which occurs in about a quarter of the population. OCT angiography shows that this area still has a relatively preserved capillary plexus and is responsible for the preservation of the normal retinal architecture here in the superior macula. And this is in contrast to the area affected by the disease, where we see that blurring of the inner retina, and this is due to intracellular edema in response to the ischemic damage from the arterial occlusion. Though it thickens initially, over time we'll see this area thin due to atrophy. This patient was taken to the emergency department. Though she had an elevated ESR and CRP, she had a normal biopsy to rule out giant cell arteritis. But her MRI showed multiple strokes as well as carotid occlusion, and she underwent an emergent carotid endarterectomy. On follow-up 2 weeks later, she now shows the more classic fundus findings of retinal whitening. And so initially she had presented too early to be able to see the classic cherry red spot seen with a central retinal artery occlusion. Again, you can see the area of normal perfusion due to her cilioretinal artery and the preserved retinal architecture that's responsible for her stable vision. And so this is a diagnosis of an acute central retinal artery occlusion. This is important to recognize, not only to triage the patient, but the AAO recently came out with new guidelines regarding how and when to refer. Within 24 hours, 24 to 48 hours, the patient should be referred to a stroke center. Within 48 to 14 days, they should be followed up within 48 hours to a TIA center or ER. You always want to make sure in these patients that you're ruling out giant cell arteritis and that you follow them over time. About 15 to 20% will develop neovascularization of the angle and iris. Unfortunately, that's also what happened in this patient. She was treated with PRP laser and Avastin. This is an example of a Holland horse plaque that you can see here, this refractile body embedded within one of the arterioles. About 75% of these can be asymptomatic, but though this is not an emergent referral, these patients should be referred for a workup, as up to 9% can have an ipsilateral carotid stenosis. Vascular occlusions of the vein can also be followed closely. OCT angiography can be especially helpful in more chronic forms. Here you can see the fluorescein shows few changes, but on OCT angiography, we're able to see the abnormal foveolar vascular zone responsible for this patient's vision changes. The next case is a 62-year-old female with a one-day history of painless acute vision loss. Her vision in the right eye had decreased to hand motion. She had a history of hypertension. So here we can see hemorrhage in multiple layers, subretinal, sub-ILM, and subhyaloid. You can see it here as well on the OCT. On angiography, we're able to see the subretinal blood here. Though you can see the hemorrhage, you can also see the blood vessels clearly overlying it, indicating its location underneath the retina. This is in contrast to the sub-ILM and sub-hyaloid blood, which is blocking the retinal architecture. And interesting in this case, the subhyaloid heme is actually leaking out into the vitreous, and you can watch that shadow dripping out on the angiogram, which I think is really interesting. So this is a ruptured retinal macroaneurysm with subretinal hemorrhage. The patient underwent vitrectomy and was found to in fact have a relatively large submacular hemorrhage affecting the fovea, and so she was treated with subretinal TPA and a fluid air exchange. You can see here improvement in vision from hand motion to 20/40 with some areas of atrophy secondary to that subretinal bleeding. This is a video showing OCT angiography. This I'll often use in my clinic because I think it's a nice way to visualize the lesion, especially if the patient has had a more chronic microaneurysm, and so I don't need to get angiography. So moving on to choroidal neovascularization. This is really a time where OCT angiography can be especially helpful and often can visualize the choroidal neovascularization better than conventional fluorescein or ICG angiography. I'll use it in a number of different situations. This is dry age-related macular degeneration, and I'll use OCT angiography to look for areas of subclinical CNVM. Dry AMD with pseudovitelliform detachments. Pseudovitelliform lesions can occur in association with pattern dystrophies, but also more commonly as a complication of reticular or cuticular drusen. And these pseudovitelliform lesions don't respond to anti-VEGF and hold a relatively good visual prognosis, but it's important to identify so that you don't mistreat the patient. And so OCT angiography can be especially helpful to ensure that you're not missing a choroidal neovascular lesion that could be complicating. This is an example of dry AMD. There's no subretinal fluid, no hemorrhage, but you can clearly see a choroidal neovascular network here on OCT angiography. And this is another example here with a choroidal neovascular membrane in dry AMD. These are important to identify. Dr. Phil Rosenfeld, where I trained at Bascom, has published that subclinical CNVM can have up to a 15-fold higher risk of conversion to exudative AMD compared to patients without a subclinical CNVM. In wet AMD, I will often use OCT angiography to better characterize the lesion. Here you're able to see the blood flow showing intraretinal blood flow with an intraretinal cyst consistent with retinal angiomatous proliferation or a type 3 CNVM. OCT-A also allows non-invasive tracking of a CNVM over time. And so this is the same patient after anti-VEGF treatment, and you can see resolution of that neovascular network. This is a 65-year-old female who presented with decreased vision in the right eye. And this is a subtle finding here, but there's a yellow-green vascular lesion that's visible on fundus photos. When we overlay the OCT, we're able to see a visible polyp with a branching vascular network on the OCT. Using OCTA, the superficial slab shows the polyp corresponding to the area that we saw on OCT. And then using the corresponding V-scan, we're able to see an area of blood flow within that sub-RPE area consistent with the branching vascular network. It's more clearly seen here in the sub-RPE and RP layers, and then the deep outlines are visible, clearly showing the polyps in the BVN. And so this is a diagnosis of polypoidal choroidal vasculopathy. This is important to distinguish between classic AMD because these patients can often be more anti-VEGF resistant and often will respond better to PDT or photodynamic therapy. PCV can show better visualization on OCTA compared to ICG. And this is partly due to the fact that though angiography is a dynamic test, that leakage of dye can also obscure some of the details of the vascular network. This is a 50-year-old male with a history of recurrent central serous chorioretinopathy in both eyes. He initially presented with decreased vision in the right eye for 2 to 3 months, and here he is, 20/70 in the right eye. He was treated with focal area laser to an area of leakage with improvement in the subretinal fluid, and the vision improved to 20/30. He was lost to follow-up and 3 years later presented with decreased vision in the left eye from 20/30 down to 20/200. This is his autofluorescence, and you can see the modeled hyper and hypo autofluorescence as well as the guttering that's classic for central serous. The fundus photo shows areas of hemorrhage in the macula. And OCT angiography confirms the presence of a choroidal neovascular membrane. This is a diagnosis of central serous chorioretinopathy with a choroidal neovascularization. This patient, and here we can see that there's a thickened choroid, also classic for this disease. This patient was treated with anti-VEGF injection, and you can see improvement in that fluid, as well as decreased vascularity of that choroidal neovascular network. The vision, fortunately, also improved, though did not improve back to baseline. OCT angiography, one of the nice features is that you can compare the angiography between two visits and actually follow the complexity of the lesion over time. This can also help to direct a treat and extend protocol to look for early signs of recurrence. So thank you so much for listening in. This was a review of retinal and choroidal vascular disease and some of the visualization techniques that we use in our clinic.
Hello, I'm Miguel Matarin. I am from Duke University, Director of the Ophthalmic Oncology Center. And I would like to share with you how important imaging is in the managing of intraocular tumors. Very different modalities, all of them are important for us, and we're going to describe some of this imaging. Our focus today is on wide-angle imaging. Making a little bit of history, that was first described by Pomerantsev in 1970. Then in 1990s, the RedCam came, and it is a contact camera. It's mainly for children, and it does have the fluorescein angiography capability. In the 2000, the Panoret from a company that is not available any longer had this Widefield contact camera, but it did not have a fluorescein capability. Optos came about around the same time. It's a non-contact camera. It does have the fluorescein angiography capability. And in the 2018, around that time, a non-contact camera, Clarus, with a FA capability came on board. And we're going today to see different images comparing the different cameras. This is a montage Clarus image of well circumscribed lesion inferiorly in the right eye. We can see some lacunae in the area. The lesion is flat. It has a halo. This is a typical congenital hypertrophy of the retinal pigment epithelium. Any photography, please look at the date, it's 2009. These pictures were taken on the left eye of this person. The lesion grew, and that the previous photos were taken by the optometrist. When we saw this lesion, we started to be concerned. Added the autofluorescence showed that there was some orange pigmentation with some retinal fluid, and the patient was 15 years old. So a growing lesion, suspicious lesion. We did treat this patient with a plaque radiotherapy and laser, and TTT laser and PRP around the lesion to prevent radiation retinopathy. This Fundus photograph is a montage image that it was on a 60-year-old gentleman where we can see this melanocytic lesion with drusen all over it. This patient was followed in institution number 1 starting in the year of 2000. The lesion showed at institution number 2 a possible growth on ultrasound. 2008, on the same institution, it grew. And we saw this patient in 2010 when we measured 2.7 millimeters, about the same in the same year. However, the patient came in an urgent basis because of this bleeding and around this area, and it proved to be growth in a mushroom-shaped lesion, and the patient was treated as a choroidal melanoma and with a plaque item 125, and this is the same patient with the regressed tumor and laser around it. Now to make some comparison about what we need in terms of intraocular tumors. Let's compare these two images from the same patient. Large choroidal melanocytic lesion, superior. In both images, we can see the optic nerve, but on the Clarus image, at least in oncology, it is very, very important to see the details, and the way we compare images is by seeing any documented growth, checking on monitoring any documented growth. So we look at the blood vessels, and clearly it's easier for us to evaluate with a more real color these large peripheral lesions. Another example, this is a montage photograph taken with another camera, where we can see a peripheral choroidal melanocytic lesion with multiple drusen over it. With another wide-angle camera, this is the view, and this is the view what we can have with the Clarus with a more real color. We see the RP changes on the drusen overlying the lesion. This gentleman was referred for a peripheral fundus lesion concern for uveal melanoma. The patient had ultrasound performed, and this proved to be no mass, and it was a large PD with some potential hemorrhage within the lesion. Patient was observed. The picture on the right, I was taken before the picture on the left. There are 2 months between one and the other, where we can see the large PED on the image on the right, and the PED disappeared later on the follow-up. This is the ultrasound showing how the PED was not present anymore. Again, we didn't do any treatment on this patient. Patient was happy for not having a tumor. 2013, this 75-year-old gentleman showed this juxtapapillary choroidal melanocytic lesion with some suspicious area for lipofuscin. There were no symptoms, no retinal detachment. This patient was followed. A few years later, there was a nodule growing from the same lesion. This is not a wide-angle image, but this is the one with the wide-angle image where we can see almost the entire fundus and the lesion showing more growth comparing the image from June to October. This is another patient. This lady was a 55-year-old lady who presented to us with this small choroidal melanocytic lesion that was not touching the nerve, but it was close enough. We asked for a previous image, and this was an image that was taken a few years earlier. And once again, look at the distance between the optic nerve and the margin of the tumor on this photograph comparing to that. We had the Clarus later on, and it's easier for us to compare even with a montage on the Clarus the entire lesion with real colors. Another patient, this is an African-American lady who was followed for a large melanocytic lesion, choroidal melanocytic lesion for some time, and she showed growth in this area. Once again, we can include the entire tumor on this image. We can see the orange pigmentation in this area and how the lesion is surpassing the foveola. This lady was a 62-year-old that was found doing a routine eye exam to have this lesion, one in the right eye, one in the left eye. We were a little surprised. Would it be possible to have a bilateral choroidal melanoma? The answer was yes. The left eye was treated before the right eye. And we also performed a biopsy, and both tumors showed that an aggressive pattern. Both of them were class 2. The one in the left was PRAME negative. This is a marker, an expression a marker for melanoma, and it was positive in the right. So the presence of in this person bilateral melanoma, both class 2, the presence of PRAME, is a high risk for metastasis. On follow-up, once again, it's giving us better details how these tumors look with real color. And they were well regressed, and the person still did not develop any metastasis. What about this image? This is a 40-year-old gentleman with this wide angle image. I will show you the montage on the Clarus, and I'll give you a few seconds to see where the problems are. Right there. This patient had an juxtapapillary retinal hemangioblastoma, and there was a second lesion suspicious for that. And this patient has a known von Hippel-Lindau disease. Another patient. This is a patient who did not have von Hippel-Lindau disease, but he did have this retinal hemangioblastoma, solitary, some exudation, some inflammation in the macular area. A few months later, he showed more exudation, received some treatment, some bleeding, and we're still seeing this patient. So this was a retinal hemangioblastoma with exudates. This 19-year-old female was seen in the hospital when she was admitted, and she was receiving treatment for leukemia in April of this year. Now, in order to be fair, yes, these photographs are RedCam photographs. The RedCam photograph is contact camera that has a very bright illumination. So it's very hard for the patient when they are adult or when they are not under anesthesia to tolerate the RedCam. But I think that the resident and the patient, they did a great job taking these pictures. When the patient, after she was released from the hospital, these are the images taken in our clinic. That was a month after the first pictures, and how all the hemorrhages disappear 2 months later. A melanotic choroidal mass, April of 2017. This lesion was found by the optic nerve. That's the OCT that showed an excellent fovea, no subretinal fluid. The patient was observed. This is the Optos wide-angle image. Few years later, he showed some growth in thickness, some subfoveal retinal fluid. The patient was treated with PDT, and this was the reaction to the laser with normal fovea and regression of the tumor. This patient had a bilateral choroidal amelanotic lesions with a history of non-small cell lung cancer with very symmetrical lesions superior to the optic nerve with subretinal fluid. The right eye was treated with photodynamic therapy, and the patient at the same time received systemic treatment. These were the OCTs before the treatment, and these are the images after the treatment. Once again, the right eye, so both eyes received systemic chemo, and the right eye also had photodynamic therapy, showing a better regression than the left eye, but both tumors showed nice regression, as we can see on the OCT. Once again, right eye, systemic chemo and photodynamic therapy, and the left eye, only systemic chemotherapy. So in summary, wide-angle imaging is critical for the diagnosis, management, and follow-up for intraocular tumors. It can be used, it has to be used in children and adults. We're happy that this is the Clarus is a non-contact camera, giving us real color, and the fluorescein angiography and ICG are possible. Thank you.
Awesome. Great cases. Thank you for that discussion. And we have our panelists joining us again live, and happy to take any questions from you. You know, I saw you both use photodynamic therapy, and I wondered about the process of imaging that. How do you measure this lesion now you're treating? Is there really, you know, in the AMD days, it was always the one disc area wider than the spot size or what we were trying to choose. Tell me about how it works both for you, Miguel, and for you, Sarah, in your practices now.
Oh, usually what I'll do is I will trace the lesion, usually on ICG, occasionally on FA, depending on exactly what the pathology is. Then I take the largest diameter. I add about 300 micrometers as opposed to the full disc diameter, so a little bit smaller addition. If it's a foveal lesion, I do half fluence PDT, and then peripheral, I'll do full fluence.
Mm-hmm.
The way we measure is in millimeters and using the indirect ophthalmoscope, and it depends on tumor size and tumor location. So when the lesion or the tumor is it's big enough that it's hard to measure in again 1.5 millimeters, which is the diameter of the optic nerve. That's what we use. For small lesions we use that, but for larger lesions we use the indirect ophthalmoscope with a 20 diopter lens. Mm-hmm. So the way to measure the diameter, the 20 diopter lens, if the lesion fills the whole lens, that's 12 millimeters. Then based on that, we estimate. And regarding the tumor thickness, we use the ultrasound, and for smaller lesions, we can use both ultrasound and OCT.
Mm-hmm. Combined modality imaging, which of the modalities do you particularly use a lot of, and where do you see it going? How about Sarah? Which ones do you use together a lot, where it has to be on the same device, it makes sense, versus being in the future where you see it going?
So I definitely will use fundus photography and classic fluorescein angiography fairly commonly. I think especially when I'm looking at diabetics, a lot of the pathology you can pick up subtle ND in the periphery, and I think we're seeing that more and more coming out in the trials, that conventional fundus photography or angiography is missing some of these peripheral lesions. So I think it can be really helpful. I'll also use it a lot in combination if I'm doing directed PRP for vessel occlusions. I really like to just try to target in the areas of ischemia. And so that's when I think it's really helpful to go back and forth between the angiography and the fundus photo, be able to sort of overlay them, make sure I'm lasering the correct area.
Mm-hmm.
I don't want to negotiate with you, but I will use all of them.
That's a better answer.
But if I need to choose the ones that I would use the most, that would be the color, fundus photo, and fluorescein. But again, we are seeing the technology going into OCTA. We're using that right now. So hopefully we will need to inject less people in the future, and the OCTA will show us more details. But I think that for certain tumors, you need everything. And but again, if you're asking me to choose two of them, that would be color and the FA.
Okay, great. No, good. I like how you're non-compromising. I like that about you, Miguel, already. So.
Yeah, I'm sorry. There is a Rishi, there is a question about can we replace PDT with anti-VEGF treatment since PDT will not available anymore next year? I don't know what Sarah think, what you think, but PDT is gold at the Duke Eye Center, and it's being treated like, you know, it only needs security to be, you know, be careful, but I don't know if one will replace the other. That's my summary. Definitely not for vascular tumors. I don't think that will be the case. No.
Yeah, I think that might be a misnomer. I don't believe PDT is going away. In fact, I think it's coming back with a new laser next year. So I don't think that question is actually maybe correct or maybe understood properly. But so let me ask you a question, and this is more of a practical question. You know, with these multimodal cases, it becomes difficult to potentially bill for these cases. Can you give anyone some idea about what billing is like or what you should be billing when you do these multimodal scenarios? Sarah, maybe start with you.
Well, I'd say that there are some scenarios where I really want an FA and an ICG, and I think it's important for the diagnosis. And unfortunately, you just kind of take a hit on those cases. You know, if you are only getting one, you could sort of space it out, sort of depending on the pathology. But I think a lot of times if you want some of these overlapping imaging, you know, unfortunately, you just bill for one of them, and that's just sort of the way it goes. Especially when it comes to OCT angiography, you know, I think that's a great surrogate for fluorescein, especially as we're getting some more of these wide field OCTA. You can really pick up a lot of the peripheral lesions. I think it's really helpful in a lot of ways, but you know, you can't bill for that on top of the OCT. And it does take more expertise from the staff. I think there's definitely a learning curve for the clinician. So even though it's a pretty specialized skill set and we use it a lot, you know, unfortunately, we just can't bill for it really. Not yet, anyway.
Great.
So in our case, you know, billing numbers, we're doctors, and I understand that it seems that it's different between private practice and university, and I can assure everyone that there is no difference. And because universities, they need, or the academics, they need to bill and to pay and to, like private practice. So my recommendation is work with your staff and see, because they know things that we don't, at least I don't know. And we work with them. We meet, I would say, 3 or 4 times a year to see, number one, how we do, and number two, how to build better.
That's great.
But
great.
at the end of the day is we do what we think the patient needs.
Yeah. No, I think that's keeping the patient first is important. So thank you both for that. And thank you for giving those great presentations this evening. We're going to switch over to Dr. Manavan's presentation. Dr. Manavan actually is a senior scientist at Zeiss, and she's going to speak about artificial intelligence in retina. And I've had the pleasure of knowing Ninju for the past few years. Ninju and I work on a lot of research projects together. So it's my pleasure to introduce Ninju and have you take it from here on your talk. Thank you for doing this.
Thanks everyone for coming to my talk titled AI in Retinal Fundus Imaging. I'm Niranjana Manivannan. I am a senior staff scientist in the Advanced Technology and Concept Development Group in Zeiss Meditech. I mainly work on developing clinical decision support features and then products for our Zeiss Meditech. AI can be used for multiple different things. First thing I wanted to talk about is how AI can help expand the clinical perspective of the clinicians. When we talk about the future of the retinal imaging a wide field of view, or in fact, ultra wide field of view, is really important. In fact, Claris line of products does cover a very large retinal field of view through the use of montages. Traditionally, in the older cameras, when the montage is done, the quality of the montage is very dependent on how well the subject is fixating on the fixations. If the patient is not a good fixator, we will end up having a montage which will have vessel breaks or not a good quality. What we are doing in Claris is, Claris has a deep learning AI algorithm in the background which runs through all the images, and then it finds where the optic nerve head is. By tracking the optic nerve head, we know exactly how the patient is moving between one image to another image. By knowing exactly where the patient is looking, we would be able to montage these images. By using this technology, we are creating the anatomy-aware montage. The montage images which you are seeing on the screen, both the color and then the angiography montages, are created with the help of the deep learning algorithm. An AI can also be used to extend the reach of the clinicians. Zeiss VisuHealth is a CE-marked telehealth solution for automated diabetic retinopathy screening. It's been deployed in India since 2015. Through 2019 June, we have screened about more than 196,000 patients, and more than 27,000 of these patients were screened using the automated DR capability. As a result, more than 38,000 cases with pathologies has been detected. So this is just a screening solution which is made for countries like India, where the doctors does not have direct access to the patients. So these VisuHealth can be deployed in the screening center, through which we can exactly identify which subjects or patients need to be referred so that they could come and get the treatment needed from the ophthalmologist or the retina specialist. AI can help the clinicians in aiding the decision support process. What we saw in the last slide is more of a DR screening process. What I'm talking about now here is more DR severity detection. The main bottleneck in developing good performing diabetic retinopathy detection algorithm in wide field and ultra wide field images is just the lack of data. Ultra wide field and wide field images are very new technology. To develop these kind of algorithms, you usually need more than 100,000 data. When the technology is really new, the data available to develop these algorithms is pretty less. So what we are doing for Claris is, we are actually using the data which is collected using a traditional narrow field fundus images. We are using that as a first step, and we are transfer training from that point to work with wide field fundus images. By using this transfer training, we can leverage the traditional database and then use that to create algorithms for Claris, which has a completely different field of view. This is a proof of concept which was already published in Imaging in the Eye 2020, in which we use about 361 Claris images. And for transfer training part, we use 32,000 traditional fundus images from VisuScout. By using both of this together, the algorithm we developed using deep learning ResNet is giving us an accuracy of 92%. And then we are also reaching a sensitivity of about 88% and specificity of 93%. If we train an algorithm just by using wide field fundus images, you could see that the accuracy would only be 58%. But when we use our this transfer training technology of using the narrow field images first and then using wide field, we were able to achieve an accuracy of 92%. Artificial intelligence can also be used to aid the research. Geographic atrophy is an area of interest for a lot of pharmaceutical companies, and then also an area of interest in academia. Most of the groups are working to find a drug which can treat geographic atrophy and also to figure out a treatment pathway for dry AMD. When we are developing these new technologies to address geographic atrophy, it's very important to accurately trace and measure the atrophy areas. So what we are doing here is to provide an algorithm to accurately trace and measure the geographic atrophy area. Like in all the deep learning algorithms, what is difficult here is getting the annotated data. So what we did is we did a two-step development process. First, we developed a semi-automatic tool. What this tool does is when a clinician clicks on an area, it automatically populates to atrophy area around it. So this helps in faster annotation. Using this semi-automatic tool, we got our clinicians to annotate 79 fundus autofluorescence green images, which was acquired from Claris, from 62 patients. And using these images and annotations, we used a state-of-the-art UNet, which is known to give good results for segmentation. By using the UNet segmentation framework, we got an automated segmentation algorithm, which gives results which is very comparable to the expert markings. What you're seeing on the screen, the top part is the expert marking. The bottom of the panel contains the results from automatic segmentation. You could see that by qualitatively, these results match the results from the automatic segmentation is very similar to the expert marking. When we look into quantitative results, we got about an overlap ratio of 92.76% plus or minus 5.62%. There is a fractional area difference of about 4.4%. Pearson's coefficient for this algorithm is about 0.995, which is the state of the art for geographic atrophy segmentation. Thank you everyone for attending this talk. I would be happy to answer any of your questions in the next Q&A session.
Great, thank you, Ninju. Thank you for coming and giving that information. I was going to start off with Sarah, since Sarah is still on the line with us, and I'd love to ask her, what do you think are the areas, you just heard this talk that Ninju gave about artificial intelligence. What are the areas that you struggle with on a day-to-day basis where you think AI will make a big difference for you?
One of the things that I think is really interesting with the OCTA is the ability to sort of do direct comparison. So I think one of the areas that I'm sort of really excited about is sort of looking at vascular networks and sort of seeing how they change with VEGF therapy, how those networks become less complex with time, even if they don't go away completely, and what we can use that information for to help direct prognosis. And I think, most retina specialists use some form of a treat and extend protocol for macular degeneration. And I think that's one of the harder things to sort of taper and know exactly how they're responding, how that extension is going. So I'm sort of very interested in how that OCTA research will sort of go with time. I think that's a really cool area, but especially the geographic area as well. That's really, I hadn't seen that yet. Very exciting.
Mm-hmm. Ninju, this all sounds very, very high tech. How do people understand sort of the things you're presenting? Is there going to be built-in software? Is there going to be primers? How are people going to be best able to gather the tools you're putting in front of them now?
So that's a great question, Dr. Singh. The idea is some of these tools all of these tools would come with a primer. It will also come with a user manual. I'm not sure how many people will read them, but FDA will make us put them. But we will also, because that would be really elementary to explain what they are looking at, because all these things are different things and then not everyone are familiar with the terms. So there would be a primer. And I also see where these algorithms are going nowadays. Now many of the algorithms which I presented are kind of a black box, so I can totally understand the doctors asking me that why is this algorithm deciding it's a proliferative diabetic retinopathy? What is it seeing? So I see that the research going in a direction to open up these black boxes. So we are also internally doing some work, and there are a lot more publications from a lot of different groups, um, by using which we would be able to exactly predict where the algorithm is seeing, because of which it's making a decision. I say that when you have that piece of the puzzle to show what algorithm is looking at, then I think we would be able to gain more trust. At least doctor will be able to say, oh, this is looking at that. Okay, I see. Even if it's a false positive, if it is looking at an artifact, doctor can easily say, oh, it's an artifact. That's why it's because of which the algorithm is deciding. I see it like going both ways.
Yeah.
And then we do have some time before that happens. And the one thing maybe I didn't clarify in my talk was all the work which we are doing in Zeiss in AI is mainly to aid the clinicians and not to replace them. Because we understand that all we can do is only a clinical decision support tool. So I think that's where we are mainly working at.
Yeah, I'm smiling because these are the same conversations we have in our lab meeting with you about when developing some of these technologies, because I think of the fact that, you know, again, as you said, opening these boxes up and explaining to the people where they are probably the way that we can probably educate most people, because if they get a negative or a positive output from an algorithm, they want to know where the algorithm found its changes, and they want to be able to maybe learn about that. And you brought up a couple terminology points. I just wanted to make sure people understand. Can you define like the difference between artificial intelligence and maybe the terminology kicks around deep learning and what that means to people?
So artificial intelligence is something really broad. If you're teaching the computer or any program to do something automatically by learning from some data, that's artificial intelligence. So Zeiss has been doing artificial intelligence, if I would say so, for last 25 years. The first HFA algorithm which came, that is actually looking at HFA data and then was suggesting something. So that itself is artificial intelligence. What is deep learning is something which is very new, which happened in the last decade. It's just a way of doing artificial intelligence. It is much more, it has more complex algorithms. It has more layers in the networks. So if I would say artificial intelligence is a general term, deep learning is one way of doing artificial intelligence.
Great. You showed the geographic atrophy measurement software. You've also, in your research work, talked about the OCT stuff you're working on. What's going to come out first from Zeiss? And tell me about the regulatory hurdles that you go through this, because this, I mean, I think people don't understand that they are bodies that actually have to see this stuff before it goes out into practice. So tell me about that, and tell me what we expect to see from Zeiss first.
I was about to say it depends on the regulatory hurdle, you know. But to answer your question, we have a lot of things in pipeline. Most of the things which is working on the background, like the montage one which we showed, which doesn't directly affect any clinical decision, or we are not suggesting any clinical output. So those kind of things like an image enhancement, noise reduction. So those kind of thing which is happening in the background is the one which is going to come out first. They are the ones which is going to improve the workflow. Doctors can really see the difference and make their decisions, or like can see the patients more efficiently. And we are also working with Cleveland Clinic on an OCT-based algorithm, which we had some publications in RO for. That's something which we are thinking would be next. For those kind of tools, we are looking at working with regulatory agency on the next steps and see what would be the perfect timeline to put all these tools out. So the one thing is, I mean, all these things performs really well, right? I mean, we talk in the terms of, as an engineer, I talk in the term of false positive, false negative. At one point, someone told me in my team that, hey, this can be a false positive or false negative, but in the end, it's a patient. It's a patient sitting in front of a doctor waiting for a clinical diagnosis. So we have to be really, really careful about what goes out. So we are erring on side of the caution. Whatever we are putting out there, we are going to have proper studies to support and proper validation to support. So I think that's where it's going to be.
That's great. And tell me about sort of the data sets you have. I mean, one of the concerns I think might be that for these deep neural networks, when you build these networks, they take into account, you know, males versus females, maybe African Americans versus Caucasians or other races, and even across the world. How does this work? Do you have to get data sets from all of those countries, or how does this work for developing these algorithms?
Ideally, we need to get some diversity in the data set. In the algorithms which we are developing, we are making sure that we have enough diversity. And what really is important is also the validation set which we are using is completely different from the training set. And then in some cases, we are making sure the validation is coming from different countries and continents. So we are covering a particular area. But that's still a work in progress for all the groups, because you cannot cover everything in the world. You're going to find something which is pretty normal at some point, some part in the world. So we are cognizant about the bias the data set creates. So we are making sure it has some diversity. But for all the groups which is developing deep learning, I would say this is still a work in progress.
Great. That's wonderful. So glad to hear about the future technologies that you're developing at Zeiss, and thank you for the work you're doing. Thank you to Sarah, and thank you to Miguel for your discussions this evening. Thank you for joining, and love to hear your comments and feedbacks. Please provide them to us so we can make this program better in the future.